Yeah,
So,
please go ahead.
good evening, eminent faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's podcast, Pandora's Box Endoscopy, Task Series 3.0 and Episode 2. And today's topic is Ubiquitous Fibroids. So, it's my privilege to introduce the coordinator of this webinar, this podcast. It's Swara Patel, ma'am. Ma'am is the Assistant Professor, LTMMC and GH Mumbai, India, Senior Resident of Bharat Ratna Baba Saheb Ambedkar Hospital. I welcome you, ma'am, and I hand over the session to you.
Thank you so much, Saiti. I welcome you all to this third episode of Pandora's Box, and I am sure everyone is very excited for today's session. Without wasting any time, I would like to call upon today's conveners. Our first convener is our very own Dr. Niranjan Chavan. He's a professor and unit chief at LTMMC and Sion Hospital. He was organizing secretary at the recently successful AICOG Mumbai 2025, past president of MOGS in 2022 and 23, and treasurer Foxy. Welcome so much, sir. We are very excited to have you. Our co-convener is Dr. Komal Chavan. She is medical director, Chavan Maternity and Nursing Home, senior consultant DNB teacher at VN Desai Hospital, ex-honorary professor at Cooper Hospital, and vice president Foxy. Also joint organizing secretary at AICOG 2025. Welcome,
Thank you,
sir and
thank
madam.
you. Thank you so much, sir. Thank you.
So, thank you, Swara. It's a great privilege to have the stalwarts, icons of India to be present here, task series. The full form of task is trending dash ask. So all the trending people and the trending subjects are taken into consideration. Komal and I started this in 2021 during the COVID period. Then we did it in 23 and now we are doing in 25. I don't know, somehow coincidentally, it is happening in odd number of years. But that's what are the odds which we are talking today. And this will be the second episode, ubiquitous fibroid, where ubiquitous means it's present everywhere. It's omnipotent. Nowadays, women have fibroids, which are not only present in adolescent, but in reproductive age and in perimenopausal women. And I can see them that in most of these cases, they are young girls, mothers also having in pregnancy fibroid. Well, we'll go into that discussion later, but I welcome all the icons and the attendees with folded and humble, requesting you to support me for IAG Treasurer's Post. And we go ahead with this wonderful Icons of India episode 2, Pandora's Box. And I would like now to introduce the stalwarts. Can we have the slides, please? Dr. Prakash Trivedi, he is going to be reaching to us shortly. I was his registrar in 1991, past president of ISAR, past president of IAG, past president of Foxy, and he has got many records on his own and a wonderful orator, wonderful videos he shows. He will be joining us and sharing his teaching experience for more than 30 years. He is the only person who has done AAGL in India twice, and to get AAGL here is a very difficult task, and we are very proud of him for what he has done till now. And it's really great to have him. He will join us soon. Well, Dr. PC Mahapatra, what can we say? The one person who doesn't receive takes calls is Dr. PC Mahapatra. To summarize, he is nothing less than God and the sun rising from the east. And the way he speaks and his oratory skills are amazing. He was the past president of Foxy and IMA, and he was also the professor presently now having his own practice in Cuttack. He has a very roaring practice and is hobnobbing all over the world and the globe, giving lectures, orations. We will have him shortly soon. Then we move on to the most amazing lady of the Sunrise Hospital. She has not only done great work in India, but also post COVID and pre COVID in the Middle East and also in other countries. We have none other than Dr. Nikita Trehan, who will be joining us shortly. She is a world renowned gynecologist and a laparoscopic surgeon. She has the world record of removing the largest fibroid, 6.5 kg. I remember Dr. Rakesh Sinha sir also having a Guinness World Record about 3.5 kg, and that was many years ago. And this was also operated in the oldest patient of 107 years. We will hear from her intricacies and the methods of removing a fibroid laparoscopically and further as soon as she joins with us. And the most important person which is here today is a teacher of teachers, a very good orator. He has got numerous instruments on his name. To name a few, we have the forceps, we have something which is importantly used for PPH, and it's none other than Professor Piley. He has been the head of the department of Rajagiri Hospital in Kochi, has a special interest in endoscopy, open surgeries, urogynecology, and being the past president of Kerala Federation, he has taken all the southern our Indian fellows back into the mainstream of Foxy and IAG, and he is going to be here discussing about fibroids. Now I hand over the mic to Dr. Komal Chavan to say a few words and we can move on. Thank you so much.
Thank you so much. And it is a great pleasure that such a lovely program is lined up, and we have all the stalwarts. So, my deepest gratitude to all the stalwarts who have joined, and I am along with all the viewers waiting for a fabulous discussion. So, definitely, whenever there is a fibroid surgeries and the patient presents with most commonly infertility or with menorrhagia, but the every time it is the what is the patient's need, what she has presented, and that we need to, as a doctor, or as a surgeon, we need to actually deal with what is her main interest and to take care of it and to do it, because the future reproductive career of the woman is also at stake. So we have all the stalwarts who are going to tell us their important tips and tricks, how to go about, how to do the surgery effortlessly and give good outcomes. So I thank you so much, and we can just begin. And Dr. Paili sir, I'm just eagerly waiting to hear from you. Over to you, Dr. Niranjan Chavan.
Yes, thank you. Thank you, Dr. Komal, for that brief introduction. Without much ado, we have Dr. Piley with us. Sir, you are having a practice. Welcome, Dr. Piley, sir, from Kerala, Kochi. You have a practice of 40 years, I think more than that. You have been teacher of teachers, teaching fibroids. Fibroids are taught to us in MBBS also. And in postgraduate student, you can say that the resident is baptized or he has done a myomectomy. It is the most fulfilling thing, which Swara will also agree with me that how much pleasure you get. But before that, they have gone through a lot of surgical skill development, and they have gone through a lot of cases of assisting the senior registrars and the professors, and then one day, finally, they get to do myomectomy. Sir, I would like you to share few of your thoughts during your residency, which you had, and some interesting cases which you came across as you were teaching with your postgraduate students, and of course the consultants, and few complications which you could have seen or we could have managed it and tackled much more better. The mic is yours, sir. Thank you so much.
Thank you, Niranjan, Komal, Sura, and all of you in the audience for this opportunity to share our experience with fibroids. As you have correctly put it, is ubiquitous everywhere in any age group. Previously, we used to say it is in the latter half of the reproductive age, but no more. You see it in the younger ones. So over the few years, in fact, spreading over nearly more than 50 years, I can say that we have seen a very many varieties change of policies, how to tackle a fibroid, and what comes to mind are the ones that still stays. The first thing that comes to my mind is the transformation that was brought about in the management when we have a fibroid in pregnancy. And we feel very happy that we could be rather pioneers, because up until, say, late 90s, it was told that if you come across a fibroid when you do a cesarean, leave it alone. That's the most dangerous thing to tackle if you tackle a fibroid. But around about the same time, we started to think differently. We started to say that any fibroid that you would remove otherwise in a non-pregnant situation should be removed during a cesarean. This is the best time to do it. In fact, to support our views on this, we had textbook of gynecological operations. Stalworthy, for example, he had written that the best time to remove a fibroid is when you have it during a cesarean section. Reason being, when you remove the fibroid from a myometrium, you can make the uterus contract. That will control the bleeding. That was his argument. But all along, it was held, and postgraduate teachers were insistent that if you try to do a fibroid, a myomectomy during cesarean, you will end up losing the patient. We thought otherwise. And the reason why we thought differently was our experience with myomectomy in the non-pregnant situation. And that also, we grew up hearing about, the ways, the various methods, Bonnie's myoma, different techniques and all that. We used to say about the tunneling, the flap, all these things. And we changed over our technique of myomectomy to reduce the blood loss by using tunicate. Tunicate is isthmial tunicate, by which we can compress both the uterine arteries at the level of the isthmus by taking, first we started with a red rubber catheter, later we changed over to the Nelton catheter, and now we use the Foley. I will tell you why we changed. But the principle is lateral to the uterine arteries, but medial to the round ligament. Through the broad ligament, if you pierce in the non-vascular area, front to back, and then back to front, we can bring a catheter around the isthmus, tighten it further and further, and that takes away most of the blood supply to the uterus. In case it's a corneal fibroid, upper segment fibroid, we can cut away the blood supply coming through the infundibulopelvic by using a sliding knot at that point. So that makes the whole uterus totally avascular. We can take time. You can, even if you don't supply blood for the ovary for a short time, it really doesn't matter. So we started to do myomectomy in the non-pregnant state, and the same experience was then transferred over to myomectomy during cesarean. We used the tunicate, and with that, we could remove fibroids in a number, whatever location, whatever size. That went on to the level that any fibroid, our colleagues started to remove like that, and no one's concerned. Of course, if it's only a subserous fibroid, you can use a little vasopressin there. Sometimes you may not need anything, but multiple fibroids to remove during cesarean, tunicate is the best. This is what we identified. We started to do it. And one of the patients, actually, the memory remains, is a doctor colleague, not my colleague as such, a doctor, daughter of my own teacher, in fact. She had to have the pregnancy terminated because of fibroid in complicating pregnancy. It went on up to 24 weeks, and because of the size of the fibroid, the pressure it was giving onto the diaphragm, and difficulty to breathe and all that, not in our center, but outside, it was terminated at 24 weeks. And subsequently, when she came to us, we did agree that it was really large, because even after termination of pregnancy by a hysterectomy, which they did, you can imagine she still has something like a full-term pregnancy size of the uterus. But what unfortunately we realized was it was a subserous fibroid, a pedungulated one. which, if only they had known, hopefully, they could have removed during the pregnancy and allowed the pregnancy to continue. But in the post after delivery, a few months later, when she came, even then to remove that was really difficult because it was so huge. We had to make a vertical incision on the abdomen, piecemeal, big chunks of fibroid removed. Thankfully, subsequently, she got pregnant and she has 2 children now. So I was wondering, is it possible to tackle a fibroid which is creating problems during pregnancy? Certainly, if it's a subpediculated fibroid, there is no reason why we should not. Of course, if you put an incision on the uterus, that can be a problem, but there are now many reports of even removing fibroid, doing myomectomy, allowing the pregnancy to continue. Symptomatic fibroid, that's the important thing. If it's asymptomatic, leave it alone, but many fibroids will be symptomatic, especially the more subserous ones. They are the ones which undergo red degeneration, not the intramural, not the submucous. Submucous to some extent, but intramural doesn't undergo red degeneration. It's a subserous one. And the reason being, red degeneration, as we call it, is due to interruption of blood supply to the fibroid. And when there are only limited vessels supplying it, and if thrombosis occurs in that, the fibroid gets avascular, causes pain, and all its symptoms. So now the trend is changing. Not only that, during cesarean section, we will do a myomectomy. Even during pregnancy, people are doing myomectomy now. Not a deep multiple fibroids like that, but at least the symptomatic ones or large ones. The other thing about pregnancy and fibroid is they can lead to problems. They can lead to miscarriage if they are especially submucous. They can lead to torsion of the uterus. They can lead to torsion of the fibroid itself. All sorts of complications can be there. And depending on the symptom, and now we are better off because we can do ultrasound, we can do an MRI to find out the details of the fibroid. And depending on that, we can chart out what to do. So our approach to fibroid has changed of late. Fibroid complicating pregnancy has changed of late, except if it is a intramural small one, we may leave it alone. Otherwise, during a cesarean, we remove it. And that's a policy that has been adopted in many centers in Kerala, and I'm sure across the world. Even though, even now, there are people who say that fibroid, leave it alone. We don't agree with that. Recently, we had a patient from the UK, again, coming because she has such a huge abdomen and there's a growth restriction of the baby, elderly primary, and we had to pull her through and later do a cesarean and do cesarean myomectomy, where she was told that it is going to be a big problem. Hi, PCA, good evening. And so that is our experience, just to recollect what we do with fibroids as a problem in pregnancy. Coming to the management as such, myomectomy, open myomectomy, and during myomectomy to reduce blood loss, as I said, we use different techniques, but our favorite is to use the tourniquet. And the same thing that we use, as I mentioned earlier, during a cesarean myomectomy. But why we change from the red rubber catheter to the Nelton plastic tube, and now to Foley is, we use the Nelton catheter. After a while, when the plastic gets stretched, the control of blood flow to the uterus gets less, and she can start to bleed. Whereas if you have a Foley catheter, and if you pull it really tight, because of the elasticity, it maintains the constriction of the vessels, and then throughout the procedure, there will be no extra bleeding. So that is why we changed over from the plastic catheter to the Foley catheter. But there is a way to remember, if you put a Foley catheter, you have a technique of putting the tourniquet. You have to just pull the two ends up, pull it like that, again pull up like that. Then only it will get tight. Just taking a throw and tightening like that, it will not tighten enough. That is all. These are a few thoughts I thought about, Niranjan.
Yes,
Do you
sir.
want me to go on, or probably there are
Sir,
others also who have joined? Any
no, no.
questions?
Yeah, absolutely, Dr. PC sir. We just lost him in the connection. So basically, sir, we are dealing right now of something which is very interesting in pregnancy, and we will surely be there with you, sir. PC sir has some few comments also, which is regarding the pregnancy and fibroid. Sir, in the meantime, as Dr. Nikita Trehan has also joined, I have requested her because there is some public demand that if she is there, they want to see some videos, but I'm sure she's just managing that part. So basically, sir, you are talking about the use of Malicots and Foley's catheter in a pregnant state. That's what we can understand. So, what is your experience of using a myomectomy Boney's clamp in a gynec
We
case?
we have
You don't use
many early in my
Yes,
career. We had the bony club. We abandoned it after that. It is not at all very handy, not at all that useful. So we haven't used it actually. It's only for the postgraduate examination. If you want to
yes.
fail a student, you show it and they will not remember, they will not have seen it. That's all. Okay.
Yes, sir. Yes, sir. And any complications which you have seen in a patient with fibroids in your practice? PC sirs, welcome, sir. We were just discussing about the use of Piley, sir. We were all discussing regarding the use of sir had his experience of using Foley's catheter, using a Malakot's catheter around the isthmus so as to reduce the blood supply of the uterine artery going into the bed of the fibroid, sir. You have your own take. He doesn't use at all a Boney's myomectomy. He says that it is used only to fail students. What is your take, sir? I mean, we would go from you and then, hello. Yes, yes, he can join. Sir has a network issue. Yeah, yeah, he can join. Yes. Acha, okay, okay. Sahiti, there is PC sir wants to join, but there is a issue from the host side. So can you, Sahiti, just talk to sir and get him back online? Huh?
Who said? Prakash, sir?
Dr. PC Mahapatra sir, kindly take him inside.
Okay,
Okay.
sir. Okay.
Yeah, I think he has come to, twice and gone
Yeah,
back.
I could see, sir. Actually, he joined, but I think there's an issue. We'll guide, sir. Yeah, we can continue.
Yeah, I'm asking the host to join in. Allow him to join in. Yes, yes. Thank you. Yes, yes. Saiti is looking into the matter. Thank you. So, yes. Hello. Yeah, yeah. Yes, yes. We are seeing sir coming and going. Okay, sir, Nikita, thank you for joining. I know you have been waiting here for some time. There has been some technical glitch. Sir will join. We were discussing about, sir, before you joined, sir was discussing about, Piley sir was discussing about the fibroids in pregnancy and his use of Foley's and use of a Malicot's catheter in a myomectomy. Of course, you are a laparoscopic surgeon. Can you give your views? How would you proceed for a laparoscopic myomectomy? We have audience which are live on Facebook, on YouTube, and presently here also. They want to hear from your side. How would you tackle a myoma? How big you have tackled a myoma? We already are aware of the world record which you have done, and some interesting things which we will share.
So
Uh,
basically, continuing with what Dr. Piley sir was saying, cesarean myomectomy, this is a lot of PGs will also be logged on. One take home message I can say is the most avascular time in a uterus's life is postpartum. That time, if you see a fibroid, if you've done a cesarean and you've seen a fibroid, don't leave it. After you've closed the uterus and there is any fibroids, you should take it out other than cervical fibroid because of the gutter like fibers or the living ligatures there will be no bleeding. You will not need anything. So one take home which I would like to give, I'm sure Pali sir also must have said that, but there's still a lot of apprehension in people that after a cesarean, if there is a fibroid, should we tackle it, should we leave it? There are still people who are sort of saying that, am I audible, sir?
Yeah. Yes, Srihan.
Yeah, there's still a lot of people who say that, if you handle the fibroid after the baby is out and the uterus is stitched, there can be torrential bleeding, which can lead to you going in for a hysterectomy. That is wrong. Any fibroid which you find after cesarean, please take it out, and that would be one thing. There are several methods to control bleeding during laparoscopy. So during laparoscopy, when we are doing, the largest I have done is 6.5 kg, which was in Dubai, where I did a laparoscopic myomectomy which was equivalent to the size of a twins, 6.5 kg. Today I did 3 kg fibroids. So any size, any fibroids can be handled provided hemostasis is secure and your fibroid is mapped properly. And like I said, for the hemostasis, we use various agents. We use vasopressin. We use oxytocin drip. Oxytocin works on the non-pregnant uterus also. So oxytocin drip also you can start. You can put rectal mesoprost also. Tranexamic acid I'm not very fond of, but these are agents which you can use while you're doing a myomectomy. I routinely do a laparoscopic uterine artery ligation from origin in multiple fibroids or very large fibroids, so that you do not have to worry about the hemostasis during the myomectomy. And I use barb sutures. One of the things which you should use is barb sutures, because then in open surgery you have an advantage that there's someone following the thread. So you can have a uniform tension along the stitch line. But in lap surgery you have nobody following the thread. So if you have a barb suture, then you can have a uniform tension along the stitch line. Now, one thing which I like to say during a myomectomy is that the dead space should be obliterated. Whether you close it in 1 layer, 2 layer, 5 layers, it's not important. But if the dead space is not obliterated, you can have hematomas, which can lead to pelvic abscesses later, which can lead to a poor scar, which can fail in the subsequent pregnancy. I'm going to share a screen. I'm just going to share the screen with one of the cases. This was a case where somebody had done a myomectomy. One of my juniors had only done a myomectomy in Amritsar, and the myoma bed was not healed very properly. So because it was not healed properly, it caused a cesarean scar defect like a defect, which is an intramyometrial pregnancy formed there. So we all know that a cesarean scar defect, if a cesarean scar doesn't heal properly, there's a niche which forms, and that's because of the poor healing. Similarly, if a myomectomy scar is not healed, sutured properly, or there's hematoma formed, then you can have a defect there, and a pregnancy can go and implant there, and it can lead to torrential bleeding. This is called an intramyometrial pregnancy. I'm just sharing my screen. Sorry, I was not aware that I could do that earlier. Otherwise, I would have logged in from my laptop. So I'm just sharing my screen. 1 second. This video is available on YouTube. So here you can see that this was a case which was referred with an intramyometrial pregnancy. I'm doing a hysteroscopy. It's an empty cavity. And then what I've done is sorry, I hope the video is clear. So here you can see an intramyometrial pregnancy. This is not a Cornwall pregnancy. You can see that the pregnancy is inside the myometrium over there. Pali sir, is the video okay?
Yes, we can see the video. Yes.
Yeah. So here you can see that what I've done is I have done a selective both-sided devascularization, because this, if it ruptures, it can bleed torrentially. Because you remember that if you have a pregnancy in the lower uterine segment, it's still okay. Here the pregnancy grows a bit, and then because it's intramyometrial, it can bleed torrentially. So I've done a bilateral internal iliac clipping, and then I've taken a purse string suture with V-lock at the base, and then opened the sac.
Pregnancy sac.
So here you can see that it's an intramyometrial pregnancy. This is an ectopic pregnancy, exactly like how you have your cesarean scar ectopic. You can have an intramyometrial ectopic because of a poor scar of a myomectomy if it is not healed well. So this is one reason. If your suturing is not good and you've not sutured your myoma bed properly, then subsequently you can have a intramyometrial pregnancy. You can have pelvic abscesses. You can have a very poor scar which does not withstand subsequent pregnancy. So here you can see, you can stitch in 1, 2, 3 layers, but the dead space should be completely obliterated. So this is how you can see that the dead space is obliterated and hardly any blood loss is there because of the internal iliac clipping, because of the purse string at the base. Otherwise, this would have bled very heavily. So this is a pregnancy which is coming to us commonly now. This is a desi bag. We use our spinal needle bag and we make the bags in the OT. And take this bag out. And then we could see, you can take it out in the bag, that thing, and post-operatively, she healed well. Subsequently, she could become a mum. Sorry, I'll just close that screen share.
Yes. Absolutely very interesting case you have shown with an intramyometrial pregnancy. And it's amazing to see the experience which you have apart from doing a routine myomectomy. So we have stalwarts here with open surgery. Dr. Piley sir is using Foley's and Malicots, and obviously you're using the suturing technique in a laparoscopic case. A lot of cases
And Lual. Lual is something which I'm very fond of. And there is a lot of controversy which people say that, the reversible knot, that you tie the uterine artery and then you take it out. Now, if you tie the uterine artery like this and you take it out after 45 minutes, these end vessels will not get revascularized. So there are a lot of literature which is saying that the shoelace knot, etc., temporary uterine ligation is not really worth it, because uterus has a lot of other collaterals which will open up.
Okay.
I know I'm starting a controversy here.
No, absolutely. We are going to have Dr. Trivedi sir supposed to join now soon, and maybe he can highlight. But I wanted to ask now, we had one, advisory board of barb sutures, which are used in myomectomy.
Yes.
Unidirectional, bidirectional, and, there are a lot of things which are coming up, not only about barb. But what is your experience with them? Is it really the in vogue thing for doing a laparoscopic myomectomy?
I think it's not in vogue, sir. I think it's a necessity. And why it's a necessity, I just explained earlier. In open surgery, you have someone who's following your thread. In laparoscopy, you have no one. So you need the suture to remain where it is. So barb becomes almost a necessity to give a uniform tension along the stitch line. And amongst the barbs, I prefer V-lock. Why V-lock? Not the company is paying me something. The only reason why I prefer V-lock is it's heat resistant. So suppose I have to use bipolar on top of my suture, my entire stitch line will not come open. So compared to Quill or Stratafix, etc. And plus the needle of V-lock is very sturdy. So one of my very favorite sutures is V-lock. And barb suture, of course, we used to do, if I'm not using barb, if I'm using simple Vicryl #1, then I like to use interrupted. I don't like to use this continuous suture, because then I'm very nervous about the uniform tension and the stitch breaking and my entire stitch line going kaput. Then I would like to use interrupted.
Trihan, can I ask you, why are you not in favor of tranexamic acid, you said?
So I actually had one bad experience with tranexamic acid. I know we get a lot of very large uteri, and when you have very large uteri, you have the vena cava compression. So when you have the vena cava compression and you do a leg Doppler, you may have some kind of vena cava issues, which you may have some kind of ascending clots and emboli which go up. So those are the cases where I find, because most of the fibroids which come to me are very large. So I find I'm always very nervous about some kind of embolic events or deep vein thrombosis. In fact, standard procedure to give Clexane. So what I find is that tranexamic acid being a very procoagulant thing, I'm not very fond of it, because I find I want to use an anticoagulant post-op, because I've had one case where I had a very bad embolus. We had very large uterus, which was 4 kg, and I had an issue with the embolism and etc. Where I'd used tranexamic acid. Maybe it's just psychological for me. Maybe because I'm a little nervous about using any procoagulants during myomectomy.
You can understand that, but the tranexamic acid trial, they had looked at the possibility of embolic or thrombosis issues, and they said that doesn't seem to increase it. That's why I asked you. Okay. Postpartum, actually, WHO is now almost coming up. Just like other oxytocic agents, we can use tranexamic acid also. In fact, it will come into the recommendation soon. Along with oxytocin, in the active management of third stage of labor, tranexamic acid also to be given. That's likely to come up.
So I don't know, maybe like I said, it's a psychological thing to use any procoagulants once you have a bad experience. And like I said, one thing which is there, when you have very large fibroids, please do a leg Doppler and see if there are any residual things which are happening, any DVT, because once it is like a pregnancy there, sitting there for a long time. Once the uterus becomes, free of the fibroids and the uterus becomes small, all those emboli will start going up. So we've had cases where I've had to put a vena cava filter in Dubai, where it was very large. So please make sure that in large fibroids, you do a leg Doppler. That would be a very strong take home.
Thank you. Thank you, Sriha.
Anything else you'd like me to speak on, Dr. Niranjan?
Yeah. Just I wanted to know about aqua dissection and about pitresin use in myomectomy. Aqua dissection, where hydro dissection, or you put a lot of water fluid inside.
So I use a standard 0.4 microgram, that is 40 units in 400 ml of saline. I use that much of vasopressin, and that vasopressin I inject into the uterus, not into the fibroid, in one point, because if I inject it in other points, it will start leaking from there. So I inject it in one point in the uterus, because you don't want it in the fibroid. You want the uterus to retract. You want the uterus to go back and the fibroid to become blanched. It's okay, like, if the uterus is if the fibroid is not getting blanched also, the uterus should become more white there.
Yes.
So that is my standard practice.
So that is how. And what about baseball stitches?
Always, because you want less exposure of the barb. So what you do is you go inside out, inside. Baseball stitches is very, very, very standard. And you don't have to close the endometrial lining separately. Specimen retrieval is something I'm sure Trivedi sir is coming, so he will talk about in-bag. I, for one, am very fond of colpotomy, because I feel that I would want, and most of my girls want, good cosmesis. So converting a 5 mm into a 15 mm or 20 mm port, it disturbs them, so as to say. So large fibroids also, we do something called a vertical colpotomy. I dissect the rectum down, and you can take any size of the fibroid out from the colpotomy. So you create a colpotomy and you put the rectum away. I wish I had known that I was supposed to present videos. I would have selected I would have done it on my laptop. So
No,
maybe
absolutely.
next time, I'll put it on YouTube, a deep colpotomy where you dissect the rectum and go completely down and open it till the perineum, like we do in the vaginoplasty, and you will be able to take out any fibroid by colpotomy.
Yes. In the meantime, I will just go to Piley, sir. Nikita, thank you for joining. But before you leave, you can just show one video of myomectomy. I'm sure that will be possible in the next 5 minutes. If it is possible, I'll just go to Dr. Piley and just come back to you if it is possible.
Yes,
Uh,
sir. Yes, sir.
yeah,
Yes, sir. Yes, sir.
because the audience are there waiting to see some interesting one video from your side. Piley, sir,
Yes, sir.
now we are talking about vaginal myomectomy. We want to hear from you that the cases, like there are people who are doing NDVH. There are people like I was in UK. Dr. Adam Magos, he was there, and he used to do the myomectomy from the vagina. Even there are proponents like Dr. Shirish Shet, sir. He has done myomectomies. Of course, they have removed the NDVH uteruses from below. So what is your take on vaginal myomectomies?
That's something which we are doing more and more now, actually, especially the ones in the lower segment, that too posterior, and on the cervical fibroids and all that. We do remove them vaginally. The important thing is, even those with that much of laparoscopic suturing skills can do it vaginally if you have the right type of retractor and long instruments. So, being in the Society of Vaginal Surgeons of India, this is one of the areas where we feel there is more expansion possible. Vaginal approach to myomectomy. Cervical fibroids, certainly, and even lower segment fibroids. Even upper segment fibroids, you can bring it accessible through the posterior fornix. But personally, I don't. We go by laparoscopy for that. But lower segment fibroids and cervical fibroids, our preference is to remove it vaginally. We can now use dilute vasopressin to control the bleeding. Or what we do is, once we have the fibroid isolated, we can remove that mass piecemeal starting from the inside. So the capsule is left to the last. So the bulk comes down, and then you can suture better than at least those of us who don't have that much of laparoscopic suturing skills can do it vaginally. That is, yeah, we do. We do vaginally.
Sir, how much is the size you have gone ahead to remove the fibroid vaginally?
Yeah, I haven't gone more than say 7 to 8 centimeter, not bigger than that. But as Dr. Trehan said a while ago, colpotomy is a way of removing fibroids even for the laparoscopy surgeons. So if we can remove a fibroid which is already separated, we can as well remove a fibroid which is attached to the posterior surface low enough and then do like that. One thing we have to keep in mind is though, if you don't close it well, as Trehan already mentioned, and if there is collection of blood, the chance of abscess formation, infection is more if you have a laparoscopic transvaginal approach than when we have a laparoscopic approach. That we have to keep in mind. So it's important to meticulously close the bed and don't
Yes,
allow a hematoma there.
yeah. So we find hematomas which are post-operatively there, and one or two cases maybe we have also opened also back, re-explored, but it's very, very rare. But have you seen those abscesses actually with fever and then pain and then subsiding over a period of serial ultrasound being
No,
done?
I haven't. I haven't. But extrapolating with the experience that people have with endometriosis, abscess, aspiration, transvaginal aspiration, and all that, which then ends up in big abscess formation. Here also, if there is a collection of blood within the myoma bed, the possibility of infection we have to keep in mind. When you approach transabdominally in a laparoscope or open, that much of exposure to the vaginal flora is not there. Whereas transvaginally, when you go, that risk is more. However much you clean the vagina, that risk is there.
Sir, in UK, there was a trend once upon a time that if they are doing a hysterectomy and they would prefer to have the cervix being still there. like they used to do a supracervical hysterectomy. Maybe you would have seen that 20 or 25 years ago, when patients would have wanted that they need that cervix and probably also menstruation, but they have that dilemma that the uterus is removed, but at least the cervix is remaining. Have you seen such encounters in your practice? Maybe in 2000 or first decade of the 2000, that time.
UK as well as the USA, it was a very common practice. And even now, you know that many of the laparoscopy surgeons, even when they do hysterectomy, they suggest supracervical, something which we could never agree to, especially in India, Indian setting, with that much incidence of carcinoma cervix.
From a
We
cervix.
thought that is not at all a wise step to do. But now, all over the world, I think things are changing, and this fancy for leaving the service behind just for the sake of leaving the service behind is not there. Having said that, there are situations where we would like to leave the service behind. For example, when I do hysterectomy for a placenta accreta spectrum, I would leave the service behind. Reason being, in a placenta accreta spectrum, going and dissecting the cervix deep in the pelvis, that is, we are talking about abdominal approach, deep in the pelvis with the vaginal as well as the vesical plexus of vessels, you are asking for trouble. Whereas that cervix actually makes the vault of the vagina better. So that is why we do a subtotal in placenta accreta spectrum. Of course, I am deviating from the subject of the discussion. As an
Fine.
example, I was telling you, leaving the service behind sometimes may be practiced with that in mind. There was a time when people used to say that for sexual satisfaction, that is better to leave the service behind. I think by a randomized trials, they have shown there is no value in saying they like that. But leaving the service behind certainly leaves a problem because the squamocolumnar junction is still left behind. The most vulnerable part which can undergo changes and later on end up with malignancy is there. So if at all you leave the service behind, we should also talk about vaccination, which is available recently and now, and also regular follow-up. So we don't, to answer your question, we have not been recommending and still we don't. And I think across the world, more and more people are going away from this idea of leaving the service behind, except some of the laparoscopic surgeons still say supracervical hysterectomy. And there is the other thing is, some people say for prolapse, they will leave the service behind and do a sacrocervicopexy as a support for the vault of the vagina. Again, I don't find as a thing which I would recommend, but of course, people are having different views.
Absolutely. Uh, Thank you for being with us, sir. Sir, last question I would like to ask you, that you had taken a patient for myomectomy and it bled a lot. The patient had gone in hypotension, probably, and of course, we take a consent for hysterectomy. Did it happen that you had to do a hysterectomy, unfortunately, in such case? Did it ever happen like this?
No, not for myomectomy, but when there was a mistaken diagnosis of an extensive adenomyosis as fibroid, and when we attempt to do myomectomy, in such cases, you may end up probably because there is no limit to your dissection, and finally you may end up converting that to a hysterectomy. But purely for myomectomy, it hasn't happened to me, even though I will always, in the discussion, talk to the patient that in case it becomes necessary, we may have to consider removing the uterus, but it hasn't happened.
Sir, yeah, thank you. Sir, there's one question from Dr. Amita Suchak, madam. She is from Malad, Mumbai. What is the, I mean, of course, I'm taking this question late, but it has come at 8:21 p.m. What is the advantage of keeping cervix behind? That was regarding the supracervical case. What is the advantage?
I know theoretically, as I said, I am not for it, but theoretically, the advantage is there is less chance of postoperative problems. It is the vault stitches that usually creates problems, other than, of course, the stumps. So if you leave the cervix behind and take both stitches for the cervix, the problems that you usually get from the vault are not there. That is the reason why many people stop short of removal of the cervix. But the disadvantage, we already mentioned why we don't want to. The other argument was, suppose you are forced to do a hysterectomy and you can leave a cervix behind, and for your own safety, you can say that part of the uterus is still there, like that. But these are not everyday issues.
Absolutely. So I think that is a valid answer given to Dr. Amita Suchak's question. Well, sir, you talked about pregnancy, you talked about using Malakots, you talked about using Foley's much better. Nikita talked about how to go about to do a myomectomy, and she has shown a wonderful video of an intramyometrial pregnancy and how she had absolutely taken a purse string and taken it back so that there was a wonderful, surgery being there. The use of barb sutures is still prevalent, which is going on now, and it's more important that you do the baseball sutures. That's what we can understand much more, and it's quite aesthetic and quite better off cosmetically also to remove a fibroid by vaginal route or by a colpotomy rather than increasing the size of the incision from 5 to 15, and it will not be good on the abdominal scar after doing a laparoscopic surgery. That's what we can gather about. And of course, we have various methods of doing myomectomy, hydrodissection, aqua dissection, using VLOC or Petricin. But at the end of the day, you need to do a proper surgery and achieve a good closure of the bed of the myoma so that you don't have hematomas and unfortunately an abscess which comes into picture. Open surgeries are also to be done, and it can be done by the best of the best hands. But always remember, if you're going ahead with the skills of laparoscopy, you need to do it in a proper fashion and in a way which is skillful, and the patient can go home as early as possible. Well, sir, you also talked about the vaginal myomectomies, and it can be done very nicely. A great way of going ahead and also removing the cervical fibroids, especially the posterior wall fibroids, which can be removed from the posterior colpotomy, and that is a much better approach rather than doing an abdominal surgery. Higher the contour of the fibroid with the fundal fibroid going up till 28, 32 weeks is size is not the importance of trying to show that I did a big fibroid or removing. Morcellation is very important, in back morcellation. That's what we can understand, and it has to be done in a proper manner, as we are aware of the famous case of endometrial cancer in a doctor who was there, and that led to her death, and there was a big hue and cry that we should not do a morcellation just open. We need to do an in-bag morcellation, and it can be a simple glove, or it can be a plastic bag of a catheter, or it could be absolutely a good in-bag morcellator. So all take-home points were covered, and I'm sure most of the members who have been participating in this wonderful episode 3 have gone with good take-home messages. Dr. PC sir has some issues about technical issues of joining. We tried to get him online. He was here 2 times, but his personal assistant could not get through it. We are still trying, and I'm sure if possible, we can make him to join. Dr. Trivedi sir is still busy operating, and I hope he comes. But in that case, we will be putting online some videos which are there so the members can take in the comment section the videos of Dr. Trivedi and Nikita Trian. So I have requested them. Sir, I would also request Dr. Piley, if you can forward me those videos, we will put it on YouTube in the comment section so that they enjoy the surgeries. Thank you so much for giving your valuable time. And
Thank you.
thank you,
So,
Dr.
I
Thank
have
you,
one last
Niratha.
question if you are
Yes.
available.
Please
Yeah,
go ahead.
Yes, yes. As surgeons, we should also know when not to operate. And I continuously have patients in OPD who come with incidental findings of fibroid. So initially, we were taught that if it's more than 4 centimeter, then we should operate. But so, what is the size ratio that we should follow beyond which you would recommend operating? And what are your thoughts on medical methods? Uh, of treating fibroids, and sometimes they are not in favor of operating if they don't have a lot of symptoms.
the question is to me.
Yes, sir. Yes, sir. It's
Yeah,
you.
okay. to coming to the last point that you raised about the medical management, personally, I am not a fan of that. I don't employ. I do admit that mifepristone might, to some extent, reduce it. And of course, the other methods of medical management are out. And personally, I don't recommend it. I don't use it. And other reason being, if you continuously give it, okay, but later when you stop it, there is a chance of regrowth. That is why. The other method, of course, you remember the focused ultrasound uh,
Yes.
treatment, ablation. Again, I think it had its own time and maybe not all that popular, even though there are centers where they still use it. Embolization as a way of cutting away the blood supply to the uterus, hoping that it will slowly come down in size. Again, personally, I am not for it. It is um, causing a lot of pain following that. Chance of regrowth is there, and because of that, people just tying off the uterine artery alone during using a laparoscopy again as a treatment without removal of the fibroid. Personally, I am not for it. If there's a fibroid to be removed, I remove. The question is, what size do we say to be removed? What size not to be removed? I think we have to take into account a lot of factors. Even a small fibroid which is submucous causing problems, if it is 1 or 2 centimeters, of course you have to remove it. The same on the outside. A subserous fibroid of the same size, we will leave alone. Somebody with a fibroid in the perimenopausal age, not very keen to get it out, I will support it. Because postmenopausally, many of them will shrink and will not create problems. But it's a submucous fibroid, I would remove it. So we have to individualize the case to decide what will be the best way to manage in a particular patient the particular fibroid. Generalizing that, I would say, personally, I'm not a fan of medical management. Second thing, submucous fibroids, even if it is small, if they are symptomatic, we have to remove. And especially in the menstruating age group, even the postmenopausal age, if they come to you and if you see bleeding, better to remove it. Intramural and subserous ones, our usual policy is if they are asymptomatic, just observe. But if they are symptomatic, of course, we have to remove. Pedunculated fibroids also can undergo torsion, just like the ovarian tumors or ovaries. And pedunculated fibroids also can lead to torsion of the uterus. Pedunculated fibroids in the submucous plane can go to inversion of the uterus. All these are relatively rare, so I don't think that should take much of our time. So I hope I have touched what you wanted me to.
Yes, yes. Thank you so much.
Okay, sir.
Swara, I really
Yes.
appreciate that you have taken up this point. So today's episode is complete. We have discussed open, we have discussed laparoscopy, we have discussed myomectomy with different techniques. We have discussed how big a fibroid can go ahead to operate and how small you should not operate, and medical line of treatment which are used. And I'm sure most of the obstetrician and gynecologist would prefer to do a surgery. And of course, there is something of infertility with fibroid. We will take that in episode 3. We have got wonderful people lined up. All of you are going to join us on 11th of February, where we are going to also discuss about submucous fibroid, hysteroscopically removed, and endometriosis. So that will come in the next episode. So fibroids are ubiquitous. Whether you go above or whether you go open or you go hysteroscopically, you are going to find them. The only way is to tackle them the best. And of course, we also discussed about the point of using HIFU. HIFU is a very big game changer. It's more commonly used in China and in Southeast Asia. There are big centers here in India also which have come, and I get patients. And you recollect that one patient had emailed us from USA, Texas, 23-year-old girl. She is having a big fibroid of 32-week size. She wants an appointment, and we will be operating her very soon in February, at the end of February. But I'm sure there are certain cases which we need to tackle. As sir also suggested, that we need to take into consideration the age of the patient, the fertility, and the number of fibroids and the route of fibroids to be decided. But as far as possible, You need to have a balanced approach. That's what I can say. Yes, sir.
Thank
I
you,
hope.
Niranjan. Thank
Yes,
you.
thank you so much. And thank you
Thank
all
you.
attendees who are there. We'll share the videos in the comment section. And I thank the whole team of Shield Connect, Sahiti, who has been there, being so nice to be with us and going ahead. And of course, Dr. Swara and Komal to make this whole episode a lively, interactive session with all of you being there participating. Have a nice, great night. Thank you so much, sir.
Thank you so
Thank
much.
you. Thank
Thank
you.
you.